So welcome everybody, and thank you so much for dialing in to this evening's webinar. We're very excited to take a look at pathology and neuroendocrine tumours and have a look at them under the microscope, and we're so thrilled to have Professor Anthony Gill join us this evening from Sydney. So I'm just going to briefly introduce Anthony, and then we'll leave you in his capable hands, and he's going to hopefully explain lots, and I'm looking forward to learning lots too. So Anthony is a Professor of Surgical Pathology at the University of Sydney and current Chairman of the Australian Pancreatic Genome Project. He actually graduated in medicine from the University of Sydney in 1997, so he's so young. but he got a truckload of awards, including the Harry J. Clayton Memorial Prize for First in University in Medicine and Clinical Medicine, the Hinder Memorial Prize for First in the University in Surgery and Clinical Surgery, the Robert Scott Skirving Memorial Prize for First in the University in Medicine and Surgery, and the Royal North Shore Hospital Medal. Goodness me. He completed his specialty training in surgical pathology in 2005 and then has since divided his time between diagnostic pathology as a senior staff specialist at Royal North Shore Hospital and medical research. His research is concentrated on translating advances made in the understanding of cancer at the basic science or molecular level into diagnostic tests that can be applied in the routine surgical pathology laboratory on patient biopsy specimens. He was awarded the prestigious Benjamin Castleman Award in 2011 by the United States and Canadian Academy of Pathology, as well as the John Lowenthal Medal and a higher doctorate by publication from the University of Sydney in 2011. The New South Wales Premier's Award for Excellence in Translational Cancer Research in 2013 and the Sir Zelman Cohen University's Prize for Discovery and Medical Research in 2014. In addition to chairing the APGI, which is the Australian Pancreatic Cancer Genome Initiative, he leads the Cancer Diagnosis and Pathology Research Group, which concentrates on research in other areas of surgical pathology. He is the only Australian member of the World Health Organization Endocrine Pathology Working Group and has recently returned from Lyon, France, where the proposed WHO 2017 classification of endocrine and neuroendocrine tumours was finalised. So I'm sure you'll be joining with me in being delighted to welcome Anthony. Thank you so much, Anthony, for joining us. I'm going to switch off my webcam and hand the controls over to you and look forward to sitting back and learning lots. Just to let people know, if you've got questions along the way this evening, there's a little text box on the bottom left-hand side of your screen, which you're welcome to write any questions down, and I'll be monitoring that text box through the conversation, and we'll have a session some time at the end for questions and answers. So without further ado, thanks Anthony. And
all right, thank you Kate, and thanks for coming along. It's my pleasure to be here. We might as well get going. I've been talking about the pathology of neuroendocrine tumours, or pathology and neuroendocrine tumours, and the specific things I want to discuss is what is a neuroendocrine tumour, and part of being a pathologist is our role with classifying tumours, not just diagnosing a cancer or a neuroendocrine tumour, but grading it and classifying it in a way that has a significant impact on treatment. We want to discuss how a neuroendocrine tumour is different to other forms of inverted commas cancer, and explain key terms which I think a lot of you would have heard when pathologists discuss. That includes chromogranin, mitotic count, Ki67, and necrosis. So we might start in what is a pathologist, or what do we actually do in a working diagnostic basis. So a pathologist, or a surgical pathologist like myself, is a specialist medical practitioner. A lot of pathologists, a lot of people who have a fellowship at the college might do blood work, say clinical haematology as well as laboratory-based haematology, but most pathologists working full-time in the industry work in surgical pathology, or what used to be called anatomical pathology, and that is diagnosis based on tissue, either from excised tissue, so if someone has had surgery as a curative procedure for a tumour, the resected tissue isn't destroyed, it's sent to the pathology department where it's investigated and tested for all sorts of things, or on biopsy, and most people with most tumours are diagnosed on biopsy or confirmed on biopsy, and that gets run through our department. So although blood tests are automated, pathologists make their diagnosis based on what a tumour looks like under the microscope, called morphology. And so there's a lot of subjectivity in it, as you can imagine, because really it's not machine-based. As a large part, it's basically what material looks like, particularly under the microscope. I should warn you to look away now if you're a bit squeamish, because part of pathology is we deal with resected tissues. I'll just explain how a resected specimen is worked through a lab. This is actually a portion of a resected lung which has a tumour. And what we want to do is to be able to look at areas of the tumour under the microscope and different areas to grade it and stage it. And I'll discuss what that means a bit later on. So when we get a resected organ like that, it is sent to us in formalin, which is a fixative that sterilises things and preserves things and makes it optimal for microscopic assessment, and also a pathology request form where the surgeon or physician requesting a biopsy summarises the relevant clinical history. We look carefully at the external part of the specimen, and then we dissect through areas. So we don't look at the entire specimen under the microscope, only relevant areas. So that's one of the registrars in our department, dissecting through the area. And as you can see, we've got some very sharp knives, cut through it, and you can see in this area there's a tumour just there. And so when we're deciding which part of this tumour to assess under the microscope, there's not a lot of benefit in looking at the entire area of normal lung, in this case under the microscope. What we want to do is sample the tumour representatively, enough to know that we get all the information we need, and also the normal lung. And there's a lot of sort of skill and training involved in deciding how much you need to put in to optimally assess it without putting in too much. So there's normal lung macroscopically, and there's a tumour. And what is done is that the areas of the tumour that we want to make into a microscope slide are cut up and put into one of these plastic containers that we call a cassette. And you can see it's got the patient's name and identifying details on the cassette, which have been blocked out for privacy reasons for the purpose of the discussion. And so the resected tumour gets represented, put areas like that put in. So if someone has had a colon resected, it might be quite a large specimen, but 20 or so cassettes of this size will be resected. And you can see we also resect, sample certain areas like lymph nodes to see how far the tumour is spread. The way we recognise where a lymph node is involved by tumour is by looking at under the microscope, and we look at the resection margins, because we don't just want to see what sort of tumour it is and how big it is. We want to see whether the surgeon has removed the whole tumour, how far the tumour is to the margins, and how far it's spread. And they're all the sort of criteria that are used to define the need for further treatment after definitive resection. After the material is put in cassettes, it's processed through machines which basically dehydrate the cell tissue and remove the water and replace it with alcohol-based solvents, and then they can be embedded in paraffin blocks, which are wax cast of that material you can see down here, which can be put on a microtome and cut into very thin sections, cut at about 4 to 5 microns. You can see here's one tissue block or cassette where a 4-micron bit of tumour has been cut off, and that's picked up and put on a microscope slide, which can be stained with various dyes. The most common ones we use are hematoxylin, which stains things pink, and hematoxylin, which stains things blue, and the eosin, which stains things pink. And then they can be put on a microscope slide, labelled with the appropriate details, so we can look at it under the microscope. And here we are. This is one of my colleagues with one of our registrars with a double-headed microscope, looking at material generated in that way. Now, as a side effect of that process, we issue a report, of course, and that's sort of a very defining thing that helps address future management. We have all these microscope slides which are filed away in our archives, and we also have the paraffin blocks, which were the bits of tumour embedded in paraffin, which are again filed along in the archives. And there's a requirement by our accrediting organisations to keep them for a minimum of 7 years after a patient turns 18. In a lot of ways, it's easier to keep all the paraffin blocks for 25 years in our archives and to separate who was less than 18 or more than 18 before tissue can be destroyed. And it's important to mention, because glass slides tend to fade over the lifetime. They're actually very heavy, and they tend to crack and break and fade, whereas the paraffin blocks can be used as a resource that's sort of kept there forever. And that's relevant because tumours, particularly neuroendocrine tumours, can go on for a long time, and it might be in 5 years or 10 years' time when new treatments come online, there'll be the facility to test the archived tissue to see if the new treatment's warranted. So I think, that's worth knowing what a block in the slide is. So a block is that little bit of tissue embedded in paraffin that can be kept in the archive, and you can do all sorts of things with that. Some tumours only work well, some treatments only work well if the tumours show certain things which you can test for in the paraffin blocks, and so they're a useful resource going forward as well as for patient care. Now, I suppose the next question is, what does a neuroendocrine tumour mean, or what is a neuroendocrine tumour, and how is that different to cancer or a carcinoma? And I'll emphasise that I give this sort of lecture to medical students, to medical specialists, to surgical specialists, oncologists, and it's quite a difficult concept to explain. So probably the simplest definition is what of a neuroendocrine tumour is an epithelial neoplasm with predominant neuroendocrine differentiation. That's kind of a circular definition. It just means it's a tumour that's neuroendocrine, and it rises in essentially every organ in the body. So I suppose the first concept before I want to go on any further is to say that most tumours we classify primarily by the anatomic location. So how do we separate a breast cancer from a colon cancer, from a pancreatic cancer? Well, it's what organ the tumour arises from. Very straightforward. Breast cancer arises in the breast, colon cancer arises in the colon. Now, neuroendocrine tumours are different in that they can arise in virtually every organ in the body. And as they arise in every organ in the body and show similar differentiation and progress and natural history, it makes sense to group them all together as one group. And that's pretty unique to neuroendocrine tumours, that a neuroendocrine tumour from the colon, from the pancreas and from the lung has so much more in common than they do apart. We group them all into the sort of broad definition of an NET. So that's how it differs, and that's sort of important concept number one. Now, the word neuroendocrine is in many ways confusing. And originally the concept of the neuroendocrine cell, in inverted commas, reflected a belief that these cells arose from the embryonic neural crest. Now, there's not a lot of interest in embryology, which is how the body develops from an embryo through a fetus to a mature baby, through different organs developing from a single cell. But in embryologic development, there is a part of the body called the neural crest where a lot of the neural elements and spinal cord come from. And it was thought for a long time that neuroendocrine cell tumours arise from that. And that's been completely disproven. But it was disproven after the terminology neuroendocrine became widespread. So a lot of discussion, should we change the terminology from neuroendocrine cells to just call them endocrine cells? And that was proposed, but it doesn't really work in the real world because everyone working in the field of neuroendocrine tumours and NETs knows them by that. And so the word neuroendocrine is really for historical reasons. The next concept is that neuroendocrines, we can define a neuroendocrine cell as a cell that secretes any hormone, of which the most common is a hormone called chromogranin. Now, I think most people would know that hormones do a lot to the body. Adrenaline gives you a surge of nervous energy and power. Different hormones can be involved with pregnancy and lactation, ovulation, testosterone development. So many hormones have an effect. The hormone chromogranin doesn't really have a functional role in the body. We use it to mark cells which have a neuroendocrine differentiation, but chromogranin itself doesn't really seem to do anything. You can measure chromogranin in the blood. It can be used to track the prognosis or the outcome of progress of some neuroendocrine tumours, but it doesn't have a functional status. But we use it to identify neuroendocrine cells. The neuroendocrine cells exist in whole organs. The adrenal medulla, from which adrenal pheochromocytoma arise, and paraganglia. The anterior pituitary or adenohypophysis is a purely neuroendocrine organ. The parathyroid glands and pineal glands are neuroendocrine organs. But just from a practical point of view, we don't tend to call parathyroid tumours neuroendocrine tumours. We call them parathyroid tumours. We don't call tumours arising from paraganglia neuroendocrine tumours. We just call them paragangliomas because it's a well-recognised organ from which they arise. The neuroendocrine system in the normal body has another component we can call the diffuse neuroendocrine system. And their scattered individual cells dispersed throughout organs which otherwise don't have a neuroendocrine function. So we understand that the purpose of the gastrointestinal tract is basically to absorb food, to digest it and process it and allow that to be absorbed into the body, but it also has a small component of neuroendocrine cells scattered throughout there, which have some functional role and unfortunately can also develop into tumours. And those neuroendocrine cells are dispersed throughout every organ in the body, or almost every organ in the body, where they have some physiologic role, but they can also give rise to tumours. And because the huge majority of cells in the gastrointestinal tract are not neuroendocrine, most tumours that arise in the GIT tract are not neuroendocrine, but the net tumours arise from that small proportion. So this is a histologic slide of the small intestinal mucosa. Normal small intestinal mucosa we see has what's called a villiform architecture, which are these fingers sticking up. And if we go up to a higher magnification, we can see this is the brush border, which is a microvillus structure that helps the small intestine absorb water and food and nutrients. These are goblet cells and enterocytes, which line the majority of the small intestine, again are involved in absorbing. And these 1-2 cells here with arrows on it are the neuroendocrine cells, which here we see just down in the base of the crypts. So they only represent a tiny fraction, much less than 1% of all the cells in the gastrointestinal tract as a whole, and that kind of explains why they're significantly less common than gastrointestinal tumours. So neuroendocrine cells all have a similar look under the microscope, and they all contain and secrete neuroendocrine granules. So if we look at the normal enterocytes here, they've got a certain look to their nucleus. This is the nucleus, and this is the cytoplasm. This cell here has some mucus in the cytoplasm. This neuroendocrine cell I recognise as a pathologist, but not a lot of people without the training would, as a neuroendocrine cell, because it's got what we call dispersed chromatin. So the blue part in the nucleus has an appearance that we say salt and pepper. It looks a bit, I can see someone say slides not coming up. I'm not sure whether that's the universal problem. It looks a bit speckled, which we recognise as being a feature of neuroendocrine cells. We can prove they're neuroendocrine by looking at them under the electron microscope and seeing these granules in their cytoplasm. Although what we use routinely in the routine clinical practice now is immunohistochemistry. So in immunohistochemistry, we cut a slide from the same paraffin block we used for the H&E. We stain it with a blue mark, which stains the nucleus, and then we can put an antibody onto the slide and wash away any excess. And with that antibody, we can recognize specific proteins expressed by any cell, although we use it diagnostically to find the proteins expressed by tumor cells. And that can be a way to classify the tumor. So here we are at higher power of an area at the base of the crypts. We can see normal cells here are staining blue, or the normal gastrointestinal cells are staining blue, but the brown stain, in this case for chromogranin, highlights the neuroendocrine cells. So this is chromogranin immunohistochemistry that we put on a slide. Chromogranin has no biological function in the body, but we use it to help identify neuroendocrine cells. And although on the light microscope and H&E, I could see 2 neuroendocrine cells in the normal crypts here, in this area I can see 1, 2, 3, 4, 5 neuroendocrine cells. And so immunohistochemistry for chromogranin is something that, from a practical point of view, we use to identify the neuroendocrine cells throughout the body. Now, I mentioned there's a diffuse neuroendocrine system throughout the body, and I'll just go through a few different organs where it occurs. This is the stomach, where you can see that there's normal glandular mucosa up here, and a couple of neuroendocrine cells here, which would stay with the chromogranin. Here's the lung. We have ciliated respiratory epithelium and a couple of chromogranin-positive neuroendocrine cells. This is the pancreas. And the pancreas has both an exocrine component, which secretes enzymes that help digest food, and an endocrine or neuroendocrine component. And most people with pancreatic tumours get pancreatic adenocarcinoma, which arises from the exocrine component, these glands here, or this duct here. This is the endocrine component of the pancreas, what we call the islets of Langerhans. And these islets have a normal function to secrete insulin and glucagon and a few other hormones that help regulate blood sugar levels. And it's from these neuroendocrine cells that pancreatic neuroendocrine tumours arise. So they're within the pancreas, but they're completely different to pancreatic exocrine adenocarcinomas that arise from the same organ. This is the C cells of the thyroid that gives rise to medullary thyroid carcinoma, which is that neuroendocrine tumour of the thyroid. So this is the histologic section of a neuroendocrine tumour arising in the small intestine. Here at very low power, this is the normal muscle layer in the small intestine. This is the surface epithelium of the small intestine, and here's the tumour under the microscope. This area here would be about 5 or 6 millimetres in diameter. So, in summary, the term neuroendocrine tumour means any cell showing neuroendocrine differentiation. We use chromogranin as a marker of neuroendocrine differentiation, but a lot of these cells can also secrete other hormones, both to have a physiologic effect or a pathologic effect. Although there are a whole lot of organs which are solely neuroendocrine, like the pituitary or the parathyroid gland. When we talk about NET tumours as a group, we normally talk about tumours arising in the scattered neuroendocrine system, which are tumours arising from scattered cells in organs which otherwise have a different primary function. So we mentioned that we can use chromogranin diagnostically and sometimes other substances. So here's a typical neuroendocrine tumour under the microscope. Often because they arise from the base of the crypts, they're a bit lower down than arising from the surface epithelium. And it's got a certain look that we as pathologists recognise with this speckled chromatin, and we can actually see the cytoplasm bit of granularity. Chromogranin immunochemistry here highlights the tumour and only 1 or 2 cells in the non-neoplastic bowel, so small that you can't see. And here we see chromogranin immunochemistry highlighting all the tumour cells, but not the benign stromal cells and inflammatory cells next to the tumour. And certain architectural clues that are important to us as pathologists to suggest the diagnosis, but not really important otherwise. So to expand the diagnosis of neuroendocrine tumour, a tumour from the diffuse neuroendocrine system has scattered cells in other organs that secretes chromogranin, not important clinically, but important to help facilitate diagnosis. It generally shows a typical morphology, so typical appearance under the microscope, and we see different tumours from all over the body, all over, every different tumour each day, and we use that typical appearance under the microscope to set us on a neuroendocrine track, and they're generally low grade. So I'll talk briefly about the difference between grade and stage. And when we're looking at prognosis and the natural history of any tumour, the two things that are most important are grade and stage. And often they're used interchangeably, but they mean subtly different things. So the stage of a tumour is basically a measure of how much the tumour has spread. So a tumour that has a small stage or a low stage is a very tiny tumour and hasn't spread. A tumour that has a high stage is a big tumour or a tumour that is spread. So stage is a measure of the physical size of the primary tumour and how much the primary tumour has spread, whether it has spread into other organs or outside one organ, or whether it's spread to lymph nodes or the lung or liver or bone. That's the stage, how big the tumour is and how much it has spread. The grade means something slightly different. The grade of a tumour is a measure of how aggressive a tumour is likely to be. So it's a quality that we determine by looking at under the microscope, and we try to predict by the appearance of the tumour how quickly it will grow, how quickly it will spread, what the risk of it spreading if you do nothing will be. And the grade also helps to predict what sort of treatments are available for individual tumours. So it's very important to be able to grade neuroendocrine tumours. So how is that done? Well, to understand the complexities of grading neuroendocrine tumours, you kind of have to go back to the history of pathology to realise why there's been a lot of confusion for more than 100 years. So back in the olden days, in the 19th century, pathology was purely autopsy-based. The concept of doing biopsies and looking at specimens under the microscope wasn't really recognised. And then in the mid-19th century, these two people, Langerhans and Lubash, they described encountering people with unusual tumours, and they really just described them in the scientific literature by saying they're an unusual tumour. They didn't really have photomicrograph equipment at the time. They had hand drawings, and we know by looking back at these microscope slides from 100 years ago that these were carcinoid tumours and neuroendocrine tumours, but they didn't know that at the time. They were called something completely different. So they've been around forever but not recognised until recently. About 100 or 110 years ago, this man, Obendorfer, presented a paper on neuroendocrine tumours in Germany, and 3 months later was published in a German language journal. And interestingly, he used the German word carcinoide, which is translated into English as carcinoid, to describe a tumour which looked at first glance like a cancer under the microscope, but did not behave as a cancer. So he thought they were all benign, but just looked like a cancer under the microscope at first glance, which is why he used the German term carcinoide, and that's been translated into carcinoid. Initially for something which he thought was benign, but just at first glance looks like a cancer that we might think is malignant. So that's a literal translation of one of his works. It behaves like a benign tumour despite having histological appearance of a malignant tumour. Unfortunately, or fortunately, 18 years later, in 1925, Obendorfer himself recognised that he was wrong, that some carcinoids do metastasize, so we can say they behave in a malignant manner. It's just that when they metastasize, they don't grow as quickly or grow in the same manner as other carcinomas that he had recognised. So there was an initial confusion that all carcinoids were benign, replaced by recognition that in fact some of them can go on to behave in a malignant manner, although most of them don't. And that sort of confusion has always been there in the grading of carcinoids. 30 years ago, people will talk about a benign carcinoid, commonly as the incidental finding in the appendix, and now there's no concept of benign or malignant carcinoid or neuroendocrine tumour. There's just a recognition that they all have some potential to spread, and the challenge is to predict which ones will spread and in which way they will spread. And so there's always been a recognition that grading neuroendocrines has been difficult. Similarly, there's always been a recognition that separating from other tumours has been difficult. Now, in the last 30 or 40 years, there's been a lot of evidence saying that the best way to predict the grade of neuroendocrine tumours is to summarise their proliferative activity, which is another way of measuring, of saying how fast they are growing. And there are all sorts of different ways to assess how fast tumours are growing. You know, the easiest is actually to see when it's in someone's body how long it takes to grow from one size to a bigger size. But obviously we want to see that in excised tumours or biopsy tumours from a small sample. Now, when cells grow in the body, they undergo mitosis. So this is a normal nucleus, and in the nucleus, which is this blue part in the cell, here's another nucleus here, here's another nucleus there, that's where all the DNA exists in chromosomes. When a cell divides, it spreads into mitosis, where it divides into at least 2 groups, two cells, each with a full copy of all the DNA from the original cell into 2 daughter cells. And any part of the body that's growing or dividing will therefore have mitoses. And mitoses are these figures here, which is where the blue DNA material from the nucleus condenses in preparation to spread apart into growing into a new cell. So the very simplest and very easiest way to estimate under the microscope how quickly a tumour is growing is to count these mitoses, because we know any cell in the body, as you take out of it, it will either be growing or dividing or not. If you have a tumour which has lots of cells where you can see mitoses, it means it's growing very quickly. Whereas if you have a tumour where you can't see any mitoses when you cut a section through the whole tumour, that doesn't mean it's not growing at all, but it means it's growing very, very slowly. So there's been different ways proposed to grade neuroendocrine tumours, and it's been unfortunate that different institutions in different bodies, different places around the world had their own system. So there was an American system and a European system. Some American institutions in particular had their own systems which were unique to their hospital. And that's great if you're in a large volume institution where you see thousands of neuroendocrine patients every year, and you can run your own clinical trials. But the reality is that neuroendocrine tumours are pretty rare, so there's a strong need to have a universal grading system. So you know that when you read a research publication from a big institution in America, when they're grading them in one way, that's exactly applicable to how pathologists in Australia grade the tumours or how they grade them in Italy. So the World Health Organization, which is a UN sort of funded body, has had several consensus meetings. They tend to have them every 10 or 15 years to come across grading systems for neuroendocrine tumours. The current grading system was published in 2004 for neuroendocrine tumours. In 2010, in the gastrointestinal tumour, there was a repeat grading system, classification system, which emphasised colon cancers and pancreatic cancers and other things that are relatively common, but updated the grading systems of neuroendocrine tumours in what's called the WHO 2010 grading system. And that was just at the conference in Lyon, France last month, where we finalised the WHO 2017 system, which will be released in May of next year. And I'll just emphasise how it's different, how it's the same to the grading in the same system. So under the WHO 2010 grading system for neuroendocrine tumours, it was very simple. You graded it by how quickly the tumour is growing, and there were two indices. One is the mitotic count, and the other is the Ki-67 index. Mitotic count is very simple. It's pathologists looking at a microscope slide. You look at this whole slide here, and I can see one mitosis in the middle of the field there. Here is the same mitosis at high power, and I count 10 high-powered microscope fields, which would be about 2 square millimetres of tumour under the microscope. I count how many mitoses there are in that area. If there are 2 or less, less than 2, it's grade 1. If they're between 2 and 20, it's grade 2. If there are more than 20, it's grade 3. That's a very powerful grading system. It has some problems. One is that it's based on looking at just 2 millimetres of the tumour, but some tumours can be massive, can be 10 centimetres. And if you just have a biopsy and you only see a tiny part of the tumour, it's a good reflection of the main tumour, but it's only 2 millimetres of a 10 centimetre tumour. Another area is that different tumours have different, what we call hotspots. Some parts of the tumour will grow quicker than others, and inevitably the fastest growing part of the tumour will dominate. The other part of grading is the Ki-67 proliferative index. I think that there's been a lot of emphasis in neuroendocrine tumours in the Ki-67 proliferative index. I'll just explain what that is and why it's such a big thing. The first point to make is that a Ki-67 index measures the same thing as a mitotic count, just in a different way and using a different metric. So this is the German university Baltic port state of Kiel University. And Kiel University, more than 40 years ago, they did a lot of different research in assessing different antibodies. I mentioned immunohistochemistry for chromogranin, where a new antibody that detects chromogranin can be applied to the side. They made a whole lot of different antibodies, and because it's from Kiel, K-I-E-L, they call them, Ki-1, Ki-2, and one antibody that they encountered was called Ki-67. The name comes from it being from the University of Kiel. And what they noticed is that when they applied this antibody to dividing cells, the quicker the cell was dividing, the more this protein was expressed. And this antibody has subsequently been produced in what we call different clones or different preparations recognizing the same protein. So you might have heard the term MIB1 or MIB1 and Ki-67 being synonymous. And really, MIB1, Ki-67 is a bit like the difference between Coke, Pepsi, and generic cola. They all really are measuring the same thing, with MIB1 being one particular clone, which has been a very robust clone, one particular antibody that works very well, but all measuring the Ki-67 index. So this is the Ki-67 immunohistochemistry on a slide. So this is a neuroendocrine tumour. Remember, we have the paraffin block. We cut a section of the tumour. We apply an antibody to it, and we wash it off so that we only get the cells that are expressing a lot of Ki-67 staining positively. So in this area here, we have maybe 200 cells, 150 cells, and we've got 1, 2, 3, 4, 5 that are positive out of 200. So 2.5% of all cells are positive, and that's how a Ki-67 index is generated. And there's a whole lot of computer programs that have attempted to read these Ki-67 indexes just by reading this, comparing the brown to the blue stained areas, and they work reasonably well, but they don't distinguish between, say, this cell here is a lymphocyte, which is just a benign cell that happens to be floating through the tumour. This cell here is an endothelial cell, a lymphocyte. That's a neutrophil marginating in a blood vessel, and we shouldn't count these cells in a proper Ki-67 count. All the data is being just looking at the percentage of tumour cells that are expressing this. So we can assess different levels of mitotic activity. Here's at a higher power showing a Ki-67 in a different tumour. We have 1, 2, 3 cells that are positive. That's the lymphocyte, shouldn't be counted. That's the cell, and neutrophil shouldn't be counted. Lymphocyte shouldn't be counted. Lymphocyte shouldn't be counted. Lymphocyte shouldn't be counted. We can estimate that therefore 1, 2, 3 cells out of about 150 are positive. The Ki-67 index here would be about 1.5%. And as you can imagine, to do this properly, it's actually quite laborious. The recommendations are that pathologists should count a total of 500 cells to come up with an accurate reason. And here's a tumour which has a very low Ki-67 index. So in this area here, which would be about half of one high power field, there are absolutely no positive cells. And that doesn't mean the tumour isn't growing at all, it just means it's growing extremely slowly. So that's a low grade tumour, and would normally report, just the way we report these is Ki-67 less than 0.5%, implying that you don't see any cells in 200 consecutively counted areas. This tumour has a Ki-67 above the 20% range. You can see there's a lot more cells that are positive, and this tumour has a Ki-67 that is so high that virtually every cell on the microscope is staining positively. And that's a Ki-67 of 98 or 99%, which is a tumour that's growing incredibly quickly and might be doubling in size in a couple of weeks. So in summary, the Ki-67 index is just another way of estimating how quickly a tumour is growing. It's a way of measuring a protein which is expressed by cells that are actively dividing. It is very complementary to the mitotic rate. So the current WHO 2010 grading system for neuroendocrine tumours states you should do both a mitotic count and a Ki-67 index. This actually should say 3% rather than 2%. I don't know how they got there. But if it's a mitotic rate of less than 2 per 10 high power field, so less than 2 per 2 square millimetres, or a Ki-67% index where less than 2% are positive, it's grade 1. If it's between 2 and 20 mitotic counts in 10 high power fields, an index of between 2 and 20%, or it should be 3 and 20%, it's grade 2. And if it's greater than 20 mitoses or greater than a Ki-67 greater than 20%, it's grade 3. Now I mentioned that Ki-67 and mitotic count measure pretty similar things, and so they're usually concordant. So normally if the mitotic rate is less than 2, the Ki-67 is less than 2%, but they're not always concordant. If they're always concordant, you wouldn't do both. If they're discordant, the rule is you go by the highest figure, and there's very good evidence that that works. So if the mitotic count is low and the Ki-67 index is high, you go by the higher Ki-67 index to ascribe the grade. If the mitotic rate and Ki-67 are concordant, that's fine. It's actually unusual for the Ki-67 index to be lower than mitotic rate. So that's how the WHO 2010 grading system works. And in terms of low-grade net systems, most high-grade tumours or grade 3s are a lot higher than 20%. So there was a recognition, so this was the endocrine WHO classification from 2004, and the neuroendocrine tumours, as I mentioned, they appear in every organ in the body. So when you look at breast tumours, there's a chapter in neuroendocrine tumours. Look at gastrointestinal tumours, there's a chapter in neuroendocrine tumours. In 2010, what we call the WHO Blue Book, for obvious reasons, and gastrointestinal tumours came out. And that's when the WHO 2010 grading system came out. When we revised the grading system for the endocrine pathology World Health Organization classification to come out in May next year, we reassessed neuroendocrine tumours, specifically discussing neuroendocrine tumours in the pancreas. But because of our philosophical belief that neuroendocrine tumours in every organ should be graded and staged in a similar way, there's an understanding that the WHO 2017 grading system will replace the WHO 2010 grading system for every organ stream, for every neuroendocrine tumour. So, as I said, I was at Lyon. There you are. This is a World Health Organization building. It's actually part of the United Nations. So if you had committed a crime in France, you could seek asylum, I think, in the WHO. There's, the city of Lyon. And there were several changes proposed to the WHO 2017 grading system. And part of the rules is that I can mention some of them, but I can't really explicitly put them all up there. That's been ratified and will go ahead. The first important thing to make is that there's a general agreement of the concept that the best way to grade these tumours, based on current knowledge, is on the proliferative activity of the tumour. So the concept of grading tumours based on how quickly they are growing, measured by both the mitotic count and the Ki-67 index, remains. There was a lot of discussion about what is the optimal cutoff to distinguish between grade 1, grade 2, and grade 3. There's a general recognition that, part of being a pathologist, we have to be very accurate in grading these tumours, because the difference in treatment for a grade 1 tumour is quite significant compared to a grade 2 tumour. There are certain drugs that are only accessible if you have a tumour that is grade 2, so a Ki-67 index between 2 and 20%. And so we have to be very accurate with that classification system, subdividing grade 1, grade 2, grade 3. However, there's a continuum of risk. That is, although we divide the neuroendocrine tumours into 3 big groups, grade 1, grade 2, grade 3, based on mitotic count and Ki-67, they're not rigid cutoffs. So a tumour that is just on the borderline between grade 1 and grade 2 will grow a bit slower than a tumour that's just on the borderline between grade 1 and grade 2 on the other side, will grow a bit slower than a tumour that's halfway through grade 2, but nothing magical happens when you get one more mitotic count. We've recognised for a while that tumours that just scrape into a grade tend to behave at the lower end of malignancy. So whilst WHO 2000 and whilst the cutoff between grade 1 and grade 2 will remain at a Ki-67 index of 2%, there was a lot of discussion that maybe that cutoff should be made 5%. And whilst that change wasn't made, the recommendation is that all Ki-67 data can be collected prospectively to see whether that's valid. And from a very practical point of view, when you're encountering a patient with Ki-67, if you see a patient with a Ki-67 that's just over the 2% range, so grade 2, might have a Ki-67 index of 3% or 4%, a recognition that maybe it's more appropriate to treat like a grade 1. The biggest change was in grade 3 neuroendocrine tumours. So under the old WHO 2010 system, once the tumour develops a proliferative rate of greater than 20 per 10 high power fields, or a Ki-67 index of greater than 20%, it becomes a high-grade neuroendocrine tumour or a large cell neuroendocrine carcinoma. And there's very strong recognition that tumours that have a Ki-67 index between 20 and even up to 55%, although they grow quicker than tumours with an index between 2 and 20%, they behave more like the tumours with an index between 2 and 20% than the tumours with an index well over 55%. So there will be the introduction of a new category of tumour called a grade 3 NET, or low grade but grade 3 neuroendocrine tumour, which recognises the group of tumours that have a Ki-67 index just over 20%, but aren't as massively proliferative as those which have a Ki-67 index over 55%. So they'll be separated from large cell neuroendocrine carcinomas, which will have a recognition, index of over 55%. And there's good reasons for doing that, to do with which treatments these patients will respond to. And it's pretty clear that if you've got a Ki-67 index in the grade 3 range, if it's just in the grade 3 range, like just over 20%, you'd be better off being treated more like a grade 2 tumour. That's probably the most important thing to make, that although you lump lots of different patients into 3 different categories based on the Ki-67 index, it's a continuum. The tumours keep on growing quicker and quicker as the Ki-67 index goes up. And the other thing is that the Ki-67 index can change. And the natural history, in sort of an evolutionary point of view, is if you've got a tumour, whichever part of the tumour is growing the quickest will grow the quickest, will spread the quickest, and will become dominant. So the longer a tumour remains, generally they start to grow a bit quicker, and individual clones or part of the tumour develop a higher Ki-67 index. And so that's one of the disadvantages of grading just on a tiny biopsy, that you're only seeing a small part of a large tumour, and it may not be representative of the whole tumour. So that's pretty much all I've got in the prepared talk. Maybe, should I go through some of the questions that have come up in the generic discussion, and then we can take some more questions by writing? How does that sound, Kate?
That sounds good. I'm going to stick my webcam back up again so you can see me during the conversation. So can I just say, Anthony, that was really really fascinating, and it was simple enough for me to understand. So I'm hoping that will have been helpful for other people as well. Some really good questions came through, so including a couple that are just coming through now. So we're going to work through some of them, and we'll see how much time we've got. We've got about 10 minutes before.
The first question: at what size is a tumour big?
Exactly. Yeah. Well done.
Yeah. Should we go through I'll just read through the questions here.
Yep. Sure.
Okay.
The question was, at what size is a tumour big?
Yeah. Okay. So we put in these different, so there are different rules for staging. Remember, stage is about how big a tumour is, how much it's spread, whereas grade is how quickly it's growing. There are arbitrary cut-offs that once you develop a certain size, say up to 2 centimetres in the pancreas, you increase a grade. But basically, the bigger a tumour is, the higher the stage, although you might not jump stage categories. So at what size the tumour is big is a bit like saying how long is a piece of string. The bigger it is, the higher the stage it is in sort of a continuum. Simone L, is it correct to assess that if your chromogranin A blood test is high, means that tumours are secreting high levels of chromogranin A? So the first point to make is not every tumour secretes chromogranin A. And chromogranin A doesn't really have a functional, there'll be some people I'm sure who have carcinoid syndrome from secreting serotonin, where it can cause flushing and diarrhea and genuine syndromic things. Chromogranin A doesn't really have a role in the body other than to help diagnosis and management of neuroendocrine tumours. And not all tumours will secrete chromogranin A in the blood, and there are some people who can secrete chromogranin A in the blood and not have tumours at all. So it's not quite right to say that if the chromogranin activity is high, that the tumour is active. It's quite useful for following progress in patients with a known level. As it goes up and down, can be a reflection of whether it's getting bigger and smaller, but it doesn't correlate with functionality or what other hormones it's secreting.
Can I ask another question sort of related to that, Anthony? It wasn't one that was submitted by the audience, but it's one that people have asked me. Can you tell under the microscope if the tumour is producing other hormones?
Yeah, so we mentioned that we can do immunohistochemistry for chromogranin and Ki-67. We can also do immunohistochemistry for basically not every other hormone, but almost every other hormone. So if I have a pancreatic neuroendocrine tumour, I also test it for insulin, glucagon, gastrin, somatostatin, pancreatic polypeptide, CIP. Now, I can tell that the tumour cells are producing insulin. And so if you have a functional insulin-producing tumour, we can tell that. But not every tumour that produces insulin secretes insulin into the bloodstream. So whilst we can measure the production by immunohistochemistry, it doesn't mean it's functional. So a lot of patients with mid-gut tumours would have serotonin production and carcinoid syndrome. And we can show that the tumours are producing serotonin by looking at it with immunohistochemistry under the microscope, but that doesn't necessarily mean that the patients will have it, the tumours will secrete it into the blood, and some patients that it secretes into the blood, the liver will clean it up before any other part of the body gets symptoms. So it doesn't correlate well with function. We certainly do it all the time. Some patients have Cushing's syndrome or some other hormones, and people want to know whether it's that tumour producing that hormone, and so we can certainly do it. So the answer to the question is we can test for it, and we can certainly tell if the tumour cells are producing it. It doesn't necessarily mean that they're secreting into the blood. The question was, do pathologists grade pheochromocytoma from Catherine S? One of the big changes to the WHO 2007 system will come out in May. I was actually on the adrenal and pheochromocytoma paraganglioma subgroup. There's a recognition that the concept of benign and malignant no longer applies to pheochromocytoma as paraganglioma as a group, so they all have some metastatic potential, and the devil in the detail is how to predict which tumours are likely to have a metastasize and which aren't. Things like mitotic count and T67 proliferative index don't work very well in pheochromocytomas, particularly because they're a slow-grade tumour. Some people say a T7 of 2% will grow quicker than a 1%. That's probably right. But we don't really grade pheochromocytomas in the same way, not because people don't want to try to do it, but because we've proposed all sorts of grading systems that don't seem to predict what will happen. Is it compulsory for each country to adhere to the new WHO gradings, and do you think it will change the epidemiology of NETs moving forward? Very good question. So basically, whenever you want to get something published in the major, like if you're a scientific research group, you want to get your work published in the major international peer-reviewed literature, you want your work to be recognised by other institutions, and you want other people to repeat your findings to show that it works. So on almost every publication, certainly that I've been on in the last 5 years in the field of surgical pathology cancer research, the reviewers always insist that you make a comment saying, this tumour has been graded and staged according to the WHO classification for grade and normally the AJCC/UICC classification to stage. They're the same thing, AJCC and UICC. It's an American-French thing. I don't want to use the same word, but it's the same thing. So if you want to publish something academically, it is not credible if you don't apply a Ki-67 index and the mitotic count, so you don't use the WHO grading system. As I said, even those working on the WHO recognise the system is imperfect and needs to be refined, so we have no problems with people just giving a mitotic count and a Ki-67 index, particularly if they're suggesting that maybe the cutoff should be set at a different level, because we're just tweaking at what that level would be. The whole purpose of the WHO is try to get the Americans and the Europeans in the same room. The WHO 2010 grading system has been designed to be concordant with ESNETs, and going forward, because there's a significant crossover between the two groups, it should be the universal system. So I'd be hopeful that everyone working in the area will use the WHO system. Do pathology reports include mitotic rate and Ki-67 index? That's a very good question, and it's sort of dear to my heart. So the short answer is they definitely should, but they don't always. Now, I'm Professor of Surgical Pathology at the University of Sydney, and I personally think that if a pathology report on a neuroendocrine tumour does not have both a formal mitotic count and a Ki-67 index written in the report, it's substandard. Now, that does sometimes happen. It doesn't happen in major academic units now. I completely accept that 5 years or 10 years ago, before the grading system is what it is, it wasn't required at all. And even like when I was reporting things 10 years ago, we didn't do a Ki-67 index because it wasn't part of the grading, but certainly for the last 7 years or more since 2010 came out, I think that a report that doesn't have a mitotic count and a Ki-67 index in a neuroendocrine tumour is substandard, and there's a whole lot of work I could go into in trying to standardise everyone so that we're all counting in the same ways and scoring Ki-67s in the same way, and we're actually doing a lot of work on trying to formalise that, but definitely they should have it.
Can I ask a question along that, Anthony? I'm sorry to interrupt you, but if someone has had a neuroendocrine tumour diagnosed in the last, say, 2 or 3 years, and they've happened to have a copy of their pathology report and there's no reference to Ki-67 or mitotic rate, is there any point in them pursuing, I know that most centres do keep samples of tumour tissue beyond the point of diagnosis when they've done that analysis. Is there any point in them pursuing someone else to look at that tumour cell, those tumour cells under the microscope?
Yeah, so look, I mean, definitely, some time ago, like we did a small study where we offered to review 25 neuroendocrine tumours selected by oncologists. So basically, the oncologist selected tumours where they thought the pathology was discrepant or incorrect. So they're a highly sub-selected group. So they're not just the average patient. They're a patient who the oncologists think is clinically odd or not behaving like a normal neuroendocrine tumour or hasn't had a proper Ki-67 index. And we reviewed all those, and we found, some discrepancies as you expect and some that were in keeping, but that's a select group where it's behaving oddly. If I had a pancreatic, so if I had any neuroendocrine tumour and I didn't have, so if I had any neuroendocrine tumour and I didn't have a Ki-67 index report in that or a mitotic count, I'm not fussed about whether someone actually explicitly states grade 1, grade 2, grade 3. And in some ways I don't know whether I'd want that because the grading classifications change over time, but the fact that Ki-67 cutoff and mitotic count are really important will always be the same. I would insist that the pathologist report that. And there actually is a Medicare rebate for a second opinion for pathology services for morphologic pathology, which came in about November of last year, November 2015. The requirements to access a Medicare rebate are that both the patient's treating doctor and the patient's pathologist agrees that a second opinion is required for diagnosis. And, you wouldn't have any argument if you wanted a second opinion. So, look, my advice would be for anyone who hasn't got a Ki-67 index report in their pathology report in a formalised manner to insist on it. And, you can get your treating oncologist to speak to the pathologist so you can speak to themselves and ask for that to be done. Because we keep the paraffin boxes set for a minimum of 7 years after a patient turns 18, in reality we tend to keep them for a long, long time because I think they're a good thing to keep because, a tumour can come back 20 or 30 years later and you might want to test it again. There shouldn't be any problem in doing a Ki-67 index on archived tissue. One issue is that on fine needle biopsy preparations where a fine needle's been put in and just a few cells have been sucked out, we don't really have the material in paraffin blocks. So we can't do a Ki-67 index on a lot of those preparations. Sometimes we can estimate it on the cell block, but you basically need a tissue biopsy, which is a core or an organ resected, rather than a fine needle to be able to do the Ki-67. You often, if the tumour is already behaving like a grade 2, it doesn't add a lot, but I'd want it done. Next question, will the treatments applied to patients change after May 2017? That's a really good question. There's an old sort of saying in medicine that, the questions are the same every year in the medical school exams, but the answers are different. There will be some different recommendations for guidelines of treatment, particularly for patients who have a Ki-67 index between 20 and 55%, by recognising them as grade 3 NETs and separating them from grade 3 NECs or neuroendocrine carcinomas or large cell neuroendocrine carcinomas. There's an implicit suggestion that those patients will be better off treated similar to grade 2 rather than with platinum-based chemotherapy. The optimal management is still under review, so I don't think that it will change at all when the new grading system comes out, but the grading system has been designed to future-proof it for classification so that things can be worked backwards. So we've designed the grading system for Ki-67 mitotic count so that in the future, when some current clinical trials are finished, we'll be able to see at which cutoff to better assign the grades, better assign the treatments. And finally, I think it's the last question so far. If treatments are more aligned to grading, why do the PBS align treatment to type? So that's a very, the short answer is I don't think that's justified on the part of the PBS. It's a patient with a neuroendocrine tumour in one organ with the same Ki-67 index and same mitotic count, often even the same molecular abnormalities in the tumour, you can be eligible for the drug if it's in one organ and not in another organ. It's counterintuitive, and it's not really going along with where the whole field is going, is that neuroendocrine tumours as a group arising from all different organs should be treated all together as a group. All right. Have we got any other questions or comments?
think we're pretty good. It's Kate again, and I'm hoping there might be a little slide that's going to say thank you in a sec. Here it is. Anthony, I just wanted to thank you once again for your time and your expertise and sharing so much of what you know in such a really simple way to understand.